we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
In progress.
Good afternoon. Can you hear me? Good afternoon, dear colleagues. We now come to the first scientific section. I'm Dr. Chang from Bạch Mai Hospital, Vietnam, and I'm very honored today to co-chair with Associate Professor Sung Ho Wang from Korea University. This scientific section, we will have 7 speakers from Vietnam, Indonesia, Korea. And first of all, I would like to introduce Dr. Lê Thúy Liên from Bạch Mai Hospital, who will introduce the presentation with the title Assessment of Left Ventricular Volumes, Ejection Fractions and Vaginal Wall Motion in Patients Undergoing 256 slide Eurosort Coronary CT Angiography, a comparison with 2D echocardiography. Dr. Lê Thúy Liên is now the consultant biologist and focus on cardiac imaging at Bạch Mai Hospital. Now, please welcome Dr. Liên.
Thank you very much to your kind introduction. Today, I'm honored to present my study. It's an assessment of left ventricular volume, ejection fraction, and regional wall motion patient undergoing 256 slide Eurosort coronary CT angiography, a comparison with 2D echocardiography. As you know, accurate evaluation of left ventricular volume, ejection fraction, and regional wall motion, and detection of significant stenosis of coronary artery are important factor in guiding treatment decision and providing prognostic information in patients with coronary artery disease. And nowadays, there are many methods to diagnose CAD and LV function as cardiography, CMR, coronary angiography, and 2D echocardiography is the most widely used method for LV function assessment, but the modality is operator dependent and can be impaired by poor acoustic window. Cardiac MRI has been considered the clinical gold standard for function assessment, but it is expensive and limited availability and cannot be performed in patients with implant, pacemaker, or defibrillator, much contraindication, example, claustrophobia. And coronary angiography is standard to assessment coronary artery, but invasive method. LCT, the useful method, is can evaluate the coronary artery and function at one time. Retrospective electrocardiography get DSCT allow for immediate reconstruction in any phase of the cardiac cycle, but LV and diastole and systole volume can be assessed. Two generation DSCT retrospective scan for both coronary and LV functional analysis at one time that allow radiation dose. But the purpose of our study is compare DSCT using 256 slide coronary CT angiography with echocardiography for the determination of left ventricle dimension, ejection fraction, and diastole volume and systole volume, original wall motion, as well as assessing coronary artery image quality and patient radiation load. About material method, we perform study with 100 child patients suspect or non-CAD. All the patients were scanned by echo and DSCT within 1 week. LV function parameter is calculated include ETV, ESV. We also assessment stimulation of coronary artery on DSCT. About echo, we use Philips healthcare system, and about DSCT, we use two generation DSCT of Siemens healthcare system with a retrospective spiral scan from 0 to 100% RR interval. Angiographic theory for the coronary artery is best systole percent reconstruction. Functional theory for LV function assessment 10% interval steps recon with two-phase cardiac cycle, apply workstation automate software for analysis. Here the picture is outline of the method calculator LV function. Here the finger 1 determination of ejection fraction and left LV function via the threshold-based method. A and B image is and systole, and here C and D image is the diastole, thoracic and for chamber view. And here the finger 2 is outline for the volumetric and functional analysis based on the endo and AP cardio contour. Detection in A image A is a systole and B is diastole. Here the results of calculated by single software, and single CT cardiac function provide a fully automatic evaluation of LV function. The automatic pre-processing has the data ready for functional evaluation as soon as the case is opened. The ventricle automatically segmented and software provide all relevant information for local and global function assessment. About data analytics and statistical, we use single expert operator in echocardiography and two independent expert reader in DSCT. move to result, we have analysis about general information, example, age, check, heart rate, BMI index, percent patient with hypertension, smoke, diabetes, non-CID, and sex rate. We note the LV volume in echo and DSCT and result in the table. Focus the correlation in three index include LVOF, ESV, and ADV. The correlation is strong. Index are from the 0.7 to 0.8. And p-value is significant in statistical. It's about 0.001. About LVOF in DSCT is higher than in echo. ESV is similar, and ADV is equal in the both methods. So that is the banana plot agreement between the DSCT and echo for OF, OGB, and OSV. The correlation quite good between three index, especially ADV and OSV. The table about reasonable motion in echo and DSCT, we can see a correlation is good, is excellent. It's about 97.3%, and kappa index is about 0.8. So retrospective ACG DSCT for LV function assessment is a reliable and good agreement with echocardiography. At the same time, we can perform two analysis of both LV function and coronary assessment that we can reduce radiation exposure for patient. Now there is a study about assessment LV function in DSCT is limited. And we are also much limited in our study. This is small study population, and we can need larger study population to accurate result. Here the moderately high interval step reconstruction, and there is no correlation with MRI and ESA. In conclusion, retrospective ECG DSCT is really able to evaluate LV function in patient CID with good correlation with echocardiography, overcoming their limitation. Another time to evaluate corollary with good image quality is set to global diagnostics approach. In the near future, it can be confirmed on the larger population possibility benefit from a scanner with even higher temporal resolution. And many thanks for the kind attention.
Okay, thank you, Dr. Lin, for your nice presentations. So due to the schedules, we will follow up and then come back with all the speakers at the Q&A sections. Up next, I would like to introduce Dr. Nguyễn Thị Thanh Hương from Vietnamese National Children's Hospital. Dr. Hương will present us a study about the second generation dual source CT in the diagnosis of congenital heart disease at National Children's Hospital, Vietnam. Dr. Hương actually is right now a radiologist at the Vietnamese National Children's Hospital. Now, Dr. Hương, please.
Ladies and gentlemen, I'm Dr. Nguyễn Thị Thanh Hương, the first author. On behalf of our research team, I would like to present this study. The congenital heart disease are considered as the most common congenital birth defects, comprising 1% of all live births. The congenital heart disease comprises variable entities from simple to complex congenital heart malformations associated with aortopulmonary collaterals and anomalous coronary artery. There are some different imaging modalities. The echocardiography is the initial method for the diagnosis and assessment of congenital heart disease, but this method is operator dependent and limited to the acoustic window. The conventional cardiac angiography is a gold standard, but this method has some limitation. It is invasive and exposure to the radiation. The MRI is good for anatomy and functional assessment, but this method is time-consuming and requires patient sedation. The MDCT can supply the morphology of the heart and the extracardiac vasculature. Nowadays, the DSCT has high temporal resolution and high pitch, so the scan time and the affected dose can be reduced, so it is suitable for the CTA in infants and children. The purpose of this research is to explore the clinical value of the low-dose prospective ECG triggering DSCT angiography in infants and children with complex CHD. We conducted this research on 202 patients at Vietnam National Children's Hospital from December 2020 to June 2021. We performed prospective ECG trigger CTA on DSCT somatome definition flask of cement on the patient had free breathing and sedation for all children under 5 years old. We performed the flask mode for the cardiac CTA and the sequence mode for the coronary CTA. And the images was reconstructed by AMPR, MIP, and VRT. There are some images of the DSCT room and the workstation and interpretation room. Here are some results about the general characteristic. The mean age of the patient was 24 months. The youngest patient is 1 day old, and the mean height is 74 centimeter, and the mean weight was 9.2 kilogram, and the estimated effective dose was about 0.54. This chart shows the indication for cardiac CTA was about 87.1%, and the coronary artery CTA was about 13%. In this group of cardiac CTA, the pre-operative scan was about 1/2, and the post-operative scan was about 40%. This table shows the pre-operative congenital heart disease diagnosis with different diagnosis, and the tetralogy of Fallot is the most common cyanotic congenital heart disease, which accounted 25%. And here are some examples. The first case is a girl 1 day old. She is diagnosed ectopia cordis with complete atrioventricular septal defect and double outflow right ventricle, the pulmonary atresia, and the right ventricle outflow tract obstruction associated with VSD and total anomalous pulmonary venous return. The next case is a girl 1 month old. She was diagnosed tetralogy of Fallot with pulmonary atresia, the common pulmonary trunk stenosis associated with ASD, VSD, PDA, and overriding aorta. The next case is a girl 1 month old with diagnosis was interrupted aortic arch type A associated with VSD and PDA. The next case is a girl 1 month old. The diagnosis was truncus arteriosus type A1 according to the Van Praag classification associated with VSD. The next case is a boy 3 months old. He was diagnosed with supracardiac total anomalous pulmonary venous return associated with ASD. And the next case is a girl 1 month old. She was diagnosed with infracardiac total anomalous pulmonary venous return associated with ASD and PDA. This table shows the different surgical procedure for congenital heart disease, and there are the initial phase and the multiple phase for the complex congenital heart disease repair. Here is the example of a girl. She was performed the Norwood Sinus on the patient with VSD and proximal pulmonary artery stenosis. The next case is a boy 3 years old. He was performed Glenn Sont on the patient with complete AVSD, DORV, TZA, pulmonary atresia, and dextrocardia. This chart shows the different coronary artery anomaly with the alpha was about 18% and the coronary artery aneurysm in Kawasaki disease was 37%. And this is the example of a boy 3 months old with diagnosis is alpha. And the next case, we can see the multiple coronary artery aneurysm in beta shape in both coronary artery in a patient with Kawasaki disease. In conclusion, the DSCD angiography is visible in infants and children with complex congenital heart disease and coronary artery anomalies. Thank you for attention.
Okay, thank you, Dr. Hương, for very nice image about the CHD in children. Now I would like to pass the microphone to my co-moderator, Associate Professor Sung Ho Wang. Professor Sung Ho Wang, please.
Yeah. Can you hear me? Thank you, Dr. Trang. Good afternoon, ladies and gentlemen. I'm Dr. Huang from Korea University. I'm so pleased to join ASCI Congress with you today. Now, I'd like to introduce the next speaker and interesting topics for Scientist Section 1. The speaker is Dr. Mai Hong Son. He is a nuclear physician. He has authored multiple research papers about the PET and the SPECT CT scan. Today, he will talk about a correlation between diastolic left ventricle mechanical dysynchrony parameter by gated single proton emulsion computed tomography, myocardial property imaging, and the left ventricle echocardiography indexes in early post-myocardial infarction patient. It seems very interesting. Dr. Hong Son, please.
Thank you for inviting me. I'm here to present our study correlation between diastolic left ventricular mechanical dysynchrony by gated SPECT myocardial perfusion MPI imaging and left ventricular echocardiographic indexes in early post-myocardial infarction patients. At first, I'm sorry, something wrong. I cannot move my slides. Okay. Mechanical synchrony is abnormal prolongation of the timing of contraction or relaxation between the atrium and ventricle. So here we are concerning about left ventricle, left mechanical ventricular dysynchrony, LVMD. LVMD is the result of arch failure and or myocardial infarction. So LVMD plays an important role in selection of candidate for therapy and or prediction of outcome. So systolic dysynchrony was extensively studied in heart failure. However, diastolic dysynchrony was studied less. It related to the diastolic dysfunction of left ventricle and response in patients with diastolic heart failure. Accessing LVMD can be done by standard tissue Doppler imaging because it is non-invasive, wide available, no side effect. But it depends on the operator, and the measurement of this method is variable. So we can use a cardiac MRI or gated spec MPI. Gated spec MPI is a fully automated calculation to access LVMD. However, these methods still need to be studied in further study. So recently studies show that diastolic LVMD access by gated spec MPI seems to have association with cardiovascular mortality in the coronary artery disease patient with left ventricular ejection fraction more than 35%. So aim of this study is to access the correlation between LVMD by gated spec MPI and tissue Doppler imaging TSI in early post-myocardial infarction patients. We select 140 subjects, including 106 post-myocardial infarction MI and 34 control subjects. So selection criteria: diagnostic of acute MI by European Society Cardiology guidelines. Patients must be stable on recovery phase of acute MI at least 14 days. Exclude criteria: mechanical complications of MI, arrhythmias, and or history of other cardiovascular disease should exclude from this study. Control subjects should have a normal MPI, normal sinus rhythm on ECG, without history of cardiovascular disease. A procedure ultrasound, we access DSSD. DSSD more than 34 milliseconds was considered as abnormal. TS different considered as more than 105 milliseconds as a normal. MPI was performed by ENM guidelines. The quantitative parameters for diastolic LVMD are phase standard deviation, PSD, and histogram bandwidth, HBW. PSD and HBW are higher than those of control. More than 2 SDs considered as abnormal value. Here's the steps of phase analysis on cardiac software. The significant zones was set at P less than 0.05. Here are some results of study. There is no significant difference between age of post-MI cohort and control subjects. Diastolic LVMD on MPI compared with control cohort, we can see the significant difference between PSHD and HBW between two groups. Similarly, diastolic LVMD on ultrasound also were significant difference between post-MI and control group. Here's an example of doing MPI on post-bidural cardiac infection. The HBW was wider than those of control, and PSD is lower because of the scar of myocardial infarction. So agreement between two methods. On CAGPA, we can see it is the moderate agreement. However, SPEC MPI reveal more positive case of LVMD than those of echocardiography. This graph show the moderate correlation between PSD and other parameters of DDI. Similarly to PSD, HBW also have moderate correlation with the SSD and TS different on TSI ultrasound. Relationship between ejection fraction and LVMD, there is a relationship between ejection fraction more than 40% and less than 40%. And the correlation between ejection fraction and LVMD are strong. Between PSD and HBW and ejection fraction. So finally, we would like to conclude that diagnostic diastolic LVMD parameter of GetSpec MPI and TSI cohort were higher than those of control. The phase analysis on GetSpec MPI show the moderate correlation with the SSD and TS different on TSI for the assessment of LVMD. Thank you for your attention. The last slide is a picture taken by me. Thank you.
Thank you, Dr. Song. Congratulations for your great work. Unfortunately, let me introduce next speaker because of our time. Next speaker, Pitri Kusumastuni. She works in UNS Academy Hospital, and she has. Please turn. I will turn out. I'd like to introduce next speaker because time. Moderator. Yeah, turn the screen, and now directly let me introduce next speaker. Next speaker is Dr. Pitri Kusumastuni, and he works at UNS Academy Hospital. He has studied heart failure and COVID-19. As you know, the interest of COVID-19 has increased in cardiovascular imaging because of the thrombus. And today she will talk about novel interventricular thrombus of COVID-19 healthy heart patient. Dr. Kusumastuni, please. Please play the video.
Sorry, I think I have recorded the video. Maybe the committee can play the video. Thank you.
COVID-19 is a global burden. In Indonesia, the number is still increasing drastically until today. Ladies and gentlemen, in this opportunity, I am Fitri Kusumastuni would present you a case of novel intracardiac thrombus of COVID-19 healthy heart patient. In 2019, a highly infectious virus, COVID-19, was detected for the first time in Wuhan, China. On March 2020, WHO announced it as a pandemic disease. At the same time, the first case was found in Indonesia. Besides produce respiratory complication, COVID-19 has been known to make other clinical complications to many parts of the body, including central nervous system, peripheral nervous system, gastrointestinal tract, and more importantly, to cardiovascular system and also to hematological dysfunction. These two complications may lead to the formation of intracardiac thrombus. Most of the reported cases of intracardiac thrombus mention the presence of comorbidities such as regional wall abnormality, cardiomyopathy, heart failure, or metabolic disease, or neurodevelopmental delay, and leukemia. Interestingly, unlike most of the cases reported, we found a patient with novel intracardiac thrombus with normal function of the heart. We present a case of 64 years old Indonesian male without past medical history and have not been vaccinated for COVID-19 yet. He came to the hospital with the chief complaint of lethargic and easily tired of doing light activity. It happens 2 days before. 4 days before, he has fever, followed by decrease in appetite, nausea, and vomiting. However, he denied any breathless, chest pain, thromboembolic-related symptom, or diarrhea. Despite the absence of breathless, his oxygen level was only 87% room air and increased to 98% by 10-liter oxygenation. He has slightly increase in blood pressure, heart rate, respiratory rate, and temperature. In physical examination, we found crackles in both of his lungs. However, there is no retraction. And there is normal heart, no abnormality in gastrointestinal tract, nor extremities. And we found no sign of vascular problem or sign of thromboembolic event. The presence of happy hypoxia led us to the suspicion of bronchopneumonia due to COVID-19 infection. In consequence, his chest X-ray shows increase of bronchovascular marking, and his nasopharyngeal swab shows positive result. Lymphopenia with normal leukocyte and normal blood glucose level, which is 154, and also hypocalcemia was also detected. In addition to that, he has increase of C-reactive protein, which is 3.94, and D-dimer level, which is almost 10,000 nanogram per milliliter. Echocardiography was done to rule out any cardiac abnormality, and it shows normal sinus rhythm. In order to identify the patient's main comorbidity, especially patients with hypercoagulopathy, transthoracic echocardiography was routinely performed in COVID-19 patients. The echocardiography shows normal systolic left ventricular and right ventricular function with ejection fraction of 56% and tricuspid annular pain systolic exclusion 2, normal diastolic function, and there is no dilatation of left ventricle with left ventricular and diastolic diameter 44 and left ventricular and systolic diameter is 27 millimeter. And there is also no thickness of thickened left ventricular wall, in which the posterior thickness was 11 millimeter and the interventricular septal thickness was around 9 to 10 millimeter. We did not find any valvular abnormality nor regional wall abnormality. The echocardiography was done without any use of inotropic medication. In addition to that, we found a thrombus in his apical left ventricle. The coronary angiography result was normal left mean, partially calcified plaque in proximal ostial with positive remodeling and 20% stenosis, and 30% non-calcified plaque in mid left anterior descendant coronary artery, and 60% non-calcified plaque in right coronary artery, and 30% calcified plaque in proximal left circumflex coronary artery. There was a thrombus found in his apical left ventricle with a size of 26 millimeter in weight and 11 millimeter in height. Thrombus formation is affected by endothelial dysfunction, hypercoagulopathy, and static condition. This three item has been known as Virchow triad. Coronavirus is able to bind to the angiotensin-converting enzyme 2 receptor, which is widely expressed in multiple organs. The infection of the virus in the bloodstream mediated by ACE2 receptor is highly distributed in the heart and endovascular system. The viral replication causing inflammatory cells infiltration, myocardial cells, and endothelial cells apoptosis. An aggressive viral infection induces apoptosis of lymphocyte and consequently causing lymphopenia as well as it is found in our patient. The inflamed and injury cells facilitate the recruitment of leukocytes, mast cells, macrophage, which may have important role in the immunity. The more aggressive the disease, the more massive the recruitment. The protective immune system leads to the release of molecules such as C-reactive protein, fibrinogen, ferritin, D-dimer, and pro-inflammatory cytokine, including interleukin-6. This progressive cytokine storm contribute to the activation of complement system, clotting cascade, and causing hypercoagulability. In conclusion, COVID-19 infection disrupt endothelial cells and lead to increase of inflammatory cytokines, especially in severely ill patients. COVID-19 has been known to promote thrombosis through multiple mechanisms. The previous report shows the presence of intracardiac thrombus, mostly accompanied with cardiac dysfunction. However, this case report described a COVID-19 patient with hypercoagulable state who developed intracardiac thrombus despite a normal function of the heart observed. In summary to our case, strict monitoring of coagulation parameter and early diagnosis of intracardiac thrombosis through imaging technique is very important. On behalf of Heart Failure Clinic of ONS Academic Hospital Surakarta, I would say thank you for giving us the opportunity to present our case. Come on.
Yeah, great job and a great presentation. Thank you for your work and the presentation. But Kusmas, please, Kusmas, can you hear me? Kusmas Tuni?
Yes, I can hear you, Prof.
Yeah, I wonder one question. Did you come from the regulation of interventricular thrombus after anticoagulation?
Yes, from the beginning, we have already give him intravenous anticoagulant, which is heparin. Yeah, and then also the other national guided COVID-19 therapy.
Yeah, I asked this question because the thrombus is very large, so I wonder the fate of the interventricular thrombus after treatment. Thank you for answer, kind answer. And let me move on the next topic. And before the presentation, I will inform you the change of the speaker from Sang-il Chen to Suji Kim. Next topic is feature tracking computed tomography derived left ventricular strain impact according to slice thickness of the reconstructed imaging. And the speaker Suji Kim is surprisingly she is a medical student at Seoul National University. Please play the video.
Hello, this is Suzy Kim. I'm junior of Seoul National University College of Medicine. It's my great honor to be here to present my study. The topic of my presentation today is feature tracking computed tomography derived left ventricular strain, impact according to the slice thickness of reconstructed image. My thesis advisor is Professor Sang-il Chen. To begin with, let me explain the background first. Strain refers to the change in shape resulting from contraction and is expressed as the fractional change in the length of an elementary myocardial segment in a given direction during the cardiac cycle. Myocardial strain is the significant diagnostic and prognostic factor in identifying airway dysfunction. Especially, CT-derived LV myocardial strain is visible compared to current clinical gold standard speckle tracking echocardiography. Clinically, 1 mm slice thickness of CT image is widely used without evidence, but there are some disadvantages. First, it takes up a lot of cavity. Second, it requires good performance device. And third, the loading time takes longer than thicker CT images. Therefore, the purpose of this study is to assess the clinical feasibility of variant thickness CT image-derived myocardial strain and to validate its agreement with that of 1 mm slice thickness. As you can see in picture A, there are 3 types of myocardial strain. In shorter axis view in picture B, you can measure circumferential and radial strain. In long axis view in picture C, you can measure longitudinal strain. This study was conducted with randomly selected 20 consecutive patients with stable heart rate and sinus rhythm in ECG report for CT. We used CT images obtained from dual source CT scanner, Somaton Force, which has the best temporal resolution ever. Additional functional reconstructions for dynamic assessment and quantification of LV myocardial strain were created with MediSuite program. Let me show you some examples. This is multiplanar reconstruction images of left ventricle showing apical three-chamber view. The ventricle contours are traced to analyze LV strain. From A to F, it is 1, 2, 3, 4, 6, and 8 mm slice thickness images respectively. Let's take a closer look. You can see the 1 mm slice thickness image and 2 mm slice thickness image are very similar. If you could just measure every strain by using 2 mm slice thickness images, the required capacity will be reduced by about half. This is a comparison video of 1 mm and 8 mm slice thickness image. The more the slice thickness gets, the more the clarity of MPR image decreases. Papillary muscle and coda is blurry and the margin of heart valves is unclear in picture F than A. So the strain measurements in F can be inaccurate. This is short axis view mid-phase 1, 3, 4 mm thickness images. You can see the sharpness decreases from above 3 mm images. We assessed LV strain by using picture tracking software program called MediSuite. First, you draw the contours of LV epicardial and endocardial border in MPR images manually. Then, the rest are drawn automatically by the software, which uses pattern matching technique. The maximum three-dimensional strain of the whole myocardium is then calculated and demonstrated as bullseye or Q-strain plot. Correlation between 1 mm and other thickness CT image derived strain was analyzed Pearson's or Spearman's correlation coefficient and expressed in Bland-Altman plot. We used intraclass correlation coefficient to assess the agreement. All statistical analyses were performed using SPSS statistics. This is the research result. Average age of participants were 60 plus minus 12 years. Average heart rate was about 57 plus minus 5 beats per minute, and there was little variation in heart rate. LV ejection fraction was 69 plus minus 17%. This graph shows average LV myocardial strain values by thickness. Although average longitudinal circumferential strain values are similar regardless of thickness, radial strain values show a tendency to increase from above 3 mm images. The correlation between 1 versus 2 mm longitudinal strain is 0.867 and 0.621 in 1 versus 3 mm longitudinal strain. Specific values of correlation and Bland-Altman plot are summarized in the table. You can see the longitudinal and circumferential correlation coefficient values are significant regardless of thickness, while radial 1 versus 3 mm strain values are not significant and the mean difference standard deviation was as big as 11.46. This table shows agreement between 1 mm and other slice thickness image-derived LV strain by using intraclass correlation coefficient. There is high degree of agreement in longitudinal and circumferential strains, but the radial strain isn't significant in 3 and 6 mm images. Now let's move forward with the discussion. Through picture tracking MDCT, we could quantify LV systolic function, and global LV strain has been proven to be a useful indicator for early detecting myocardial deformation and dysfunction. We assume that the role significance in radial strain is because radial strain reflects wall thickening toward the center of the LV drain systole, while others reflect shortening of myocardial fibers drain systole. It has been found in previous studies that heterogeneity of radial strain is larger than longitudinal and circumferential strain. In conclusion, Assessment of LV myocardial strain from variant thickness CT image is feasible except for radial strain. Thank you very much for your attention.
Yeah, thank you. Great job, great work. And I see the Sang Che. Can you hear me? Can you hear me?
Yes.
Too? Yeah.
Yes.
Thank you. Congratulations for great work. And after the presentation, I have one question. My question is that radiation exposure to the patient. When used the retrospective investigating CT scan, we should constant the radiation exposure. So I wonder the average radiation exposure to patient in your research and your studies. Could you tell us?
Yeah, thank you very much for your comments. Actually, as you know, we use the third generation CT named as POS. So nowadays we routinely use the 70 kVp technique, 70 kVp technique. So therefore, even so we use the retrospective gate technique. Usual radiation dose is 2 or 3 millisievert. So, except younger patient or vulnerable patient for radiation dose. So, for example, if patient age is more than 50, so we routinely use retrospective gate technique in patient with suspected or known coronary artery disease. So, also that is the one main reason why we conduct this study. So due to extremely decreased radiation dose compared to other generation, one or second generation CT. Thank you.
Thank you for your kind and detailed answers. Yes. Now let me move on the next speaker. Next speaker is Nguyen Hang Dung. She is a medical. Oh, she is also a medical student. Is it right? Yeah, current operation is she is the medical student and she has co-authored multiple publications. And so today she will talk about the severe pulmonary artery hypertension with hemoptysis in patient adult caused by patent ductus arteriosus, the diagnosis approach and the treatment strategy. Yeah, please, Dr. Dong. Yeah. Moderator, please, the video. Oh, live talk?
Well, thank you for your presentation. Well, good afternoon, Dr. Nguyễn Ngọc Trang and Professor Song Hong Quang. And dear doctor present today.
Good afternoon, Dr. Nguyễn Ngọc Trang and Professor Song Ho Kwang, and dear doctors present today. On behalf of our research group, I'd like to report a rare case with severe pulmonary hypertension caused by patent ductus arteriosus. While my presentation has two parts, a case description and discussion, and the conclusions. The patient is a 46-year-old man, and he coming from Dong Nai, Vietnam. In 2015, he was diagnosed with primary pulmonary hypertension and managed the disease with the bosentan and sildenafil. In 2020, the patient started coughing up blood, had palpitation, and breathlessness on exertion. After hemodiapsy with a total of 1,000 milliliters, he was brought to the emergency department. After retracing his record, the echocardiogram was like this. There's only the dilations of the right temples, the pulmonary hypertension, and wholly no other abnormality were confirmed. The question is, for such a patient, is it proper to diagnose primary pulmonary hypertension with the available information? Perhaps should be regarded with a more complete approach. Well, this is one of the main parts that we want to convey. A pulmonary hypertension be a condition described by increased pressure in pulmonary circulation. Divided into 5 groups, the patient with ones tend to present with non-Pacific syndrome, and hemoptysis is a rare complication that draw about 1 to 6%. Furthermore, the patient sometimes receive misdiagnosis, like in this multi-center study, the number just about 33%. So I continue present to this case at the emergency department. The chest X-ray saw a typical design of a pulmonary hypertension and a consolidation of expecting the alveolar hemorrhage. Well, a more specific investigation of hemoptysis like chest CT was performed. In addition to the sign of bleeding, a cause of pulmonary hypertension was found. That's what the PDA. The PDA was about 10 millimeter in diameter, and with that image, he could have an incomplete diagnosis of a PDA with pulmonary hypertension. Well, after being re-examined with the intention to finding the PDA, with a modified view, we can see a region aliasing. Here is aliasing, and we can straight the design of the PDA. I think the past omission could be caused by the difficult observation of the bidirectional shunt and maybe the position of the heart. So, what is the PDA? Well, it is the connection of the pulmonary artery and the aorta in the fetus and must be closed after birth. Otherwise, it affects hemodynamic and broadcast to the pulmonary hypertension and heart failure like this patient. The absolute requirement for treatment to close the PDA if possible. And to diagnose the PDA, we have many imaging assessments like this table. I mean, the gold standard in cardiac catheterization and the initial is still the echocardiograms, especially the TTA. But the problem is sensitivity just about 42%, as belong in many factors I mentioned. Well, I'd like to introduce some typical images of the PDA on echocardiogram. This is the most common view, parasternal source axis view. This is an aliasing flow from the aorta, descending aorta to the pulmonary artery. Similarly, this view used to detect the PDA, the doctor view. But this patient, he has no doctor view echocardiography. Well, with the increasing use of acute and routine clinical indications, the CT scan could lead to the incidental identification of the PDA. What I'm trying to say is that the CT had a high evaluation with the diagnosis of extracardiac vascular abnormality with the sensitivity nearly 100%. But is it routine for all cases? I'm afraid no. Well, because in Marian's approach to diagnosing congenital heart disease, the CT and CMR should be performed after the transthoracic echocardiogram. If the echocardiogram doesn't give the reliable result. Next, the patient underwent the cardiac catheterization, and it was a gold standard to assess whether he's still indicated for the PDA closure. With the ratio of the QP and QS, we could consider a shunt in the heart and confirm the pulmonary hypertension due to the PDA. The patient would try with a pulmonary antihypertensive therapy, and after 6 months, the QP, the greater QP and QS was increased. This saw the recovery of the pulmonary artery, so the disease had made to close. Well, in the series case of the Mary News, the 6 of 7 patients underwent successful occlusion, and 3 acid in them are bidirectional shunt. Although there were not sufficient guidelines for the closure of PDA with bidirectional shunts, this was a considered opportunity for patients. Beside the optimal condition by medical therapy. Well, after closing, he had no real symptom, and his exertion capacity just reduced to a third. He also felt much better and able to perform his job normally as an athlete. In short, I'll briefly summarize the main issues. The firstly, PDAs can be a misdiagnosed cause in pulmonary hypertension that can be minimized by full approach evaluation with the road CT scan in difficult cases. Second, the bidirectional sense ignores an absolute constraint indication for closer therapy in PDA, leading to severe pulmonary hypertension. Each treatment method should be suitable for each patient to improve the prognosis and the quality of life. Well, finally, thanks for your attention, and I hope you will have genuine insight into this case. That's all.
Thank you, Dong. Very good welcome, and thank you for your interesting case presentation. And your voice sounds beautiful and holy. I will now. It is time, though. I would like to turn over the podium to Dr. Trang again because time. Dr. Trang, please.
Okay, thank you, Professor Sung Ho Wang. Now I would like to introduce the last speaker of our section today, Dr. Phùng Bảo Ngọc from Vietnam, Bạch Mai Hospital. She is a consultant radiologist at the Radiology Center at Bạch Mai Hospital, and she will share with us today the topic about diagnosis of coronary artery fistula by multi-detector computer tomography. It's also a congenital topic also. So, Dr. Ngọc, please.
Good afternoon, Chairman. Good afternoon, ladies and gentlemen. Today, I will report a small study at our hospital last year. Diagnosis of coronary artery fistula by multi-detector computed tomography. Coronary artery fistula consists of abnormal communication between a coronary without the vessel of cardiac chamber. CAF are observed in 0.002% of the general population, but present in 0.05 to 0.25% of patients who undergo coronary angiography. CAG remains the gold standard for imaging the coronary artery. However, the relationship of CAF to other structure and the origin and course of CAF may not be apparent. Coronary computed tomography angiogram, a non-invasive method, can provide the benefit of better imaging clarity. The aim of this study was to evaluate the imaging characteristics of CAF by multi-detector computed tomography. Patient population during 21 months, 31 patients detected CAF from a total of 3,322 patients underwent CCGA. Two experienced radiologists reviewed the imaging. We exclude patients with poor image quality. CT data were archived with retrospective ECG-guided cardiac CT scan by 256 slide DSCT and 128 slide MDCT. All images were evaluated by two independent radiologists. The characteristics of CAF include the number and size of the fistulas, the origin and range pressure, the presence of aneurysm and coexisting anomalies. CAF were diagnosed with CCTA in 31 of 3,322 patients, 0.93%. The prevalence of CAF determined with MDCT in our study is 0.93%, was similar to the study of Jejunum and Leducnam, but was higher than the reported prevalence of 0.05 to 0.25% on CAG examination. The prevalence of CAF may have been underestimated with CAG due to some limitation for CAF imaging include canulating all of the artery with fistular origin is technically difficult, and complex configuration of the anomalous pressure and their anatomic relation with adjacent structure can be obscured on 2D fluoroscopic image. CAG was performed in 6 patients. One of them was resigned surgical treatment. 13 cases had a single fistula. The most common origin site is both the ASCI and LCA, which was similar to the study of Keishu. Some study reports the prevalence of CAF from both ASCI and LCA was only 5%. Those study was based on CAG and could not evaluate exactly both ASCI and LCA at the same time. The right side cardiac structure is the most common drainage site of CAF, and pulmonary artery was the most common site, similar to another study. But the most common drainage site of CAF based on CAG was the right ventricle. The reason for this discrepancy may be the coronary to right ventricle type can be more clearly visualized than coronary to pulmonary type by CAG. A 60-year-old woman with a LAD artery to right ventricle fistula. A 63-year-old woman with a LCX artery to left bronchial artery. A 60-year-old woman with a CAF originating from the conus, brain, and LVD running into the bronchial artery and pulmonary artery with a contraction site. Aneurysm of the fistula is an important complication. It found in 19 cases, and 14 per 19 aneurysm were adjacent to pulmonary artery. Besides, the contraction site presented in 18 per 19 in patients with an aneurysmal shock. We found that the aneurysm of the fistula was significantly related to drainage site and contraction site. Here, a 62-year-old woman with a CAF originating from the conus, brain, and LVD, running into the pulmonary artery with the contraction site and 2 aneurysmal shock. Compared with frontothoracic echocardiography, GTE, and CAG, only 12 patients with CAF were detected by TTE, in which 9 cases had a diameter more than 4 mm. Only 3 cases has a small size detected by TTE. The prevalence of CAF seen by TTE is 98.7%, which was higher than the prevalence in the CAF study. The reason for this discrepancy is this reported prevalence based on a small fistula chart. One of the limitation of TTE. Lê Anh Minh reported this prevalence was 87.4%, higher than our study because this reported based on patients who were examined by CAG with single, large, and not to a fistula chart. Compared with we had 6 patients underwent CAG, and all of them were detected CAF by CAG. So the overall sensitivity of MDCT was 100% in patients with CAF, higher than FEMIK report. The reason for this discrepancy may be this study used 16 slide MDCT with lower diagnostic accuracy. Two patients were not detected small origin sign from the conus brain by CAG because CAG cannot evaluate exactly both ASCI and LCA at the same time. Three patients were not detected coronary to the bronchial artery by CAG because all of them were complicated fistula with multiple origin sign, multiple and total fistula shock. The cause and drainage side of the CAF are visualized less rarely by Shenzi because of its two-dimensional imaging pattern. Here, a 60-year-old woman with CAF originating from the conus brain and LVD, running into the bronchial artery and pulmonary artery with the contraction sign. CIG image only show communication between the conus brain and pulmonary artery. Conclusion: the prevalence of CIS by MBCT is 0.93%. Both the RCA and LCA is the most common origin site of CIS. The most common branch site of CIS is pulmonary artery. Aneurysm of the fistula was significantly related to branch site, pulmonary artery, and contraction site. So, MBCT is a non-invasive and useful imaging modality to depict the CAF from the original site to the branch site as well as consisting abnormality. My presentation is end and thank you for your attention.
Okay, thank you, Dr. Ngọc, for your nice presentations. And now we still have time, so for some Q&A. So, and I checked on the Q&A box. We do not have a question from the audience. So, do we have any question from the speaker? Professor Sung Ho Wang, do you have any comment or other question for our speaker? Can you hear me?
Can you hear me?
Yes, I can hear you.
Yes, I missed the discussion time after the presentation. Yeah, it's a great time. I have a question that Mai Hong Son here.
Yeah. I'm here. Yeah.
Actually, I understand this synchrony parameter and the echocardiograph index, the correlation between them. Yes, I observed that. But I wonder, it's a clinical implication of SPECT. How can use this SPECT evaluation, this synchrony parameter? Please tell us the indication of SPECT evaluation of the synchrony parameter.
Thank you for your concern. So as I understand from you that you want to know how to calculate the left mechanical ventricular dysynchrony on SPECT MPI, is right?
Actually, what is the advantage of SPECT?
Yeah. I got it. So the path of SPECT is fully automated calculation because the myocardial perfusion imaging was performed, and we used that kind of data input inside the input of Emory Cardiac Toolbox. So from that software, all of left mechanical ventricular dysynchrony were generated. So based on that, it is like full automatic and more subjective method than TSI, than ultrasound. So those parameters can be used for follow-up. Yeah.
Let me go on. Dr. Ray?
Yes, can you hear me? Yes, it's okay. So maybe I would like to ask a question for Dr. Hương. Dr. Hương, can you hear me?
Yes, I can hear you.
Actually, right now for the guidelines in congenital heart disease with the MDCTs, right now we can have the good resolution and very nice image quality, especially for the children. But one thing we concern is about the radiation dose. So in your hospital, what is your protocol to reduce the radiation dose for the children?
Thank you for your question. At my hospital now.
Dr. Hương, we cannot hear you.
Can you hear me? Hello? Can you hear me? Hello, can you hear
Dr.
me?
Hương, can you hear me?
Yes, I can
right now
hear
it's
you.
better.
Okay. At my hospital now, we perform the flash mode for all the cardiac CTA, so the effective dose can be reduced as small as possible. And all the children with cardiac CTA with the effective dose is under 1 millisievert, as in our study.
Okay.
And
yes.
And in practice, we compare with the two technique. When we perform the ECG triggering and without ECG triggering, we find out that without the ECG triggering, the images is better. So all the children with cardiac CTA at our hospital now, we perform only flash mode and without the ECG triggering.
Okay, thank you for your kind answer. I still have a similar concern about the radiation dose. So I would like to ask the same question with Dr. Lien. Actually, as you know, when we do the CT, coronary CT, if you focus also on the cardiac functions, so how can you mention about the radiation dose for the patients in that case? Dr. Lien, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes.
Yeah. Thank you for your question. And in my hospital, and the patient is performed coronary artery angiography in DSCT by retrospective ECG DSCT for the LV function is with radiation dose is about 4 to 5 millisievert, and compare with the compare with the patient is perform DSCT to coronary angiography. Result of my study is equal between two patients. Between two patient group, yeah, it's equal. Can you hear me?
Okay.
Yeah.
Okay, thank you.
Dr. Train? Can I ask one question?
Yes, please.
Yeah, I have a question to Dr. Kusumastuni. Kusumastuni, can you hear me?
Yes.
Yeah, yeah. You're great. You introduced us a very interesting and very important cases, has a heart and a COVID-19 patient. So I wondering, in your institute, the echocardiograph is a routine examination in patient with COVID-19?
Yes, especially for those who have abnormality in electrocardiography or have increase in the dimer level.
Yeah. So I wonder, who need the echocardiograph and the cardiac CT? Actually, my question is that the indication of echocardiograph and cardiac CT in patient with COVID-19. Actually, exactly, your case is a healthy heart patient. He has only COVID-19. So how did you perform the echocardiography for him, the patient?
Thank you for the question. So during the examination, we found that he has elevated the dimer level. And then we found also from the electrocardiography, we find normal sinus rhythm and there is no other abnormality or sign of infection from the electrocardiography. And then during echocardiography, we found a thrombus. Then we are wondering if is it possible the patient have a low oxygen saturation, which is 87%. And then we want to evaluate the pulmonary function and pulmonary infection of COVID-19, especially for the pulmonary artery. We want to evaluate that. Because if the thrombus can be formed in the left ventricle, we are worried also if it can cause pulmonary emboli. Therefore, we send the patient for coronary CT and also to evaluate the possible occlusion of the coronary artery also.
Yeah, I understand what you meant, and I concerned the association between the COVID-19 and the cardiac and the pulmonary embolism and the cardiac thrombosis, and so many researchers have reported the association between them. So we also, in our institute, are also concerned, plan to the whether echocardiograph or cardiac CT should be a routine protocol, routine examination for the COVID-19 patient. But I think, I believe that we should plan and design the routine protocol depending on the patient symptom and the patient heart function, depending on their conditions. But in your case, you reported that has the heart patient, the patient has a heart, healthy heart, but large thrombus. It's complete to my opinion and my thing. So I consider I'm right. Yeah, I will have to study the previous researches and plan the protocol for the patient with the COVID-19. Thanks for your great case presentation. Okay, thank you.
If I may give additional information. So as we know, usually the thrombosis happen in static condition. However, during echocardiography, we doesn't find any static condition and no regional abnormality in his heart. Therefore, we are trying to find if there is really an occlusion in his coronary artery or not.
Okay. Do we still have any other comment or questions from the audience or speaker? So I think as we...
May I have one question? Sorry.
Yes, Dr. Sun, please.
Yep. My question is for Dr. Fitri Kusuma. Stuti, sorry. So, based on presentation, could you explain the mechanism of myocarditis when patient was injected with mRNA vaccine?
I beg your pardon. The last part.
Could you explain the mechanism of myocarditis when or after injection of mRNA vaccine?
So in our cases, actually the patient doesn't have COVID-19 vaccine yet, sir. At that time, it is around 2020, so we do not have any COVID-19 vaccine at that time. And then about the myocarditis COVID, we also think about that. However, from the echocardiography, we see that there is no thickening of the left ventricular wall, and the kinetic of the left ventricular wall is also quite good, which is 56%. So we are still make it as a differential diagnosis. However, because we do not have MRI yet, so we cannot really make it as a definite diagnosis of myocarditis.
Follow the question from Dr. Sun. I would like to give a comment because in this program of ASCI 2021, we will have presentations from Professor Peter Peterson. He will have a presentation about COVID-19 and myocarditis. So if you would like to have more information, even the mechanisms about this, please follow the channel and follow his presentation. So the time is over now, so we would like to close these sections. And first of all, I would like to thank you on the nice presentation from all our speakers from Vietnam, Indonesia, Korea. And thank you for my co-moderator, Associate Professor Sung Woo Wang. So please enjoy the Congress and have a nice day. Thank you and bye-bye.
Have a nice day.
Thank you very much.
Bye-bye.
Thank you for all. Thank you.
Thank you. Bye-bye.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.